This is a message for all the participants who are joining in. We are waiting for people to join in and check audio and video. All the panelists are ready to go, but we are allowing some time for the participants to join and settle down. I can see people are still logging in. We give 2 more minutes before we start. So I can see people are still logging in. Sumantra, you can unmute and be ready. There's 1 more minute and start after 1 more minute.
Okay, sir.
Yes, Sumantra, we may as well start here, and people will continue to join. Yeah.
No problem, sir. Welcome, everyone. This is Sumantro. I am from Mindful TMS Neurocare, Bangalore. I welcome you all for today's webinar on effectiveness of rTMS in treating psychiatric conditions and web-based short basic training on rTMS treatment. So I welcome you all once again. Good evening. And I'm handing over to Dr. Vijay Maitri to introduce our panelists, speakers, and guests. Over to you, Dr. Vijay.
Thank you, Sumantra. Good evening, everyone. I, Dr. Vijay Maitri, psychiatrist practicing at Mindful TMS Neurocare, Bangalore. Welcome you to today's webinar organized by Tele Arogya in association with Mindful TMS Neurocare. Today's webinar is titled Effectiveness of rTMS in Treating Psychiatric Conditions, which also includes a short basic demonstration of working of TMS. The topic will be presented by Dr. Murali, who is Professor and Chair at the Department of Psychiatry and Behavioral Neurosciences at Loyola University Medical Center in Chicago. He is also the founder of National Network of Depression Centers in India. I welcome you, sir. I'd like to welcome the moderator for today's webinar, Dr. Krishna KR, who happens to be consultant psychiatrist practicing in Bangalore and is also a chair of an organization named FRAME. The coordinators for today's webinar need no introduction. First, I would like to introduce Dr. Jagdish, who happens to be a renowned name in Indian psychiatry, consultant psychiatrist and director, Abhaya Hospital, Bangalore. Dr. Mahesh Gowda, Director, Spandana Healthcare, Bangalore. With over a decade of experience in the field of psychiatry, Dr. Mahesh Gowda specializes in general adult psychiatry, rehabilitation, and de-addiction. Next, I would like to welcome Dr. Vijay Harvichetta, consultant psychiatrist practicing in Bangalore, who has received extensive training and worked as consultant for many years at NIMHANS, who is also a lecturer at Leeds Institute of Health Sciences. He has co-authored over 30 scientific research papers and has written over 100 public awareness articles for various magazines and dailies. I welcome you all. Hoping to have a fruitful session today, I hand it over to the coordinator, Dr. Vijay Harvishankar.
I welcome everyone. Welcome to the next series of Tele Arogya. This one in association with Mindful TMS. And as you know, TMS, it's like you have an electric current, and then that gets converted to a magnet, and then gets reconverted to electricity. That people say it's a non-invasive, but we'll have to hear from the experts whether it's really a non-invasive or invasive. So uh, I had an experience of meeting the person who invented this sort of you know a tool to treat various psychiatric condition. Tony Barker in Sheffield when I was working there, as well as we used to regularly attend the conferences in Oxford run by one of the Maxim companies there regularly. When we used to meet various experts all over the world who used to come there, we used to feel it's fascinating, and we felt there were several answers that can be, whether in terms of treating and even diagnostic as well. The Sheffield where it was born, now they are doing mind mapping. Rather, they're trying to study the anatomy based on the stimulation. They've gone backwards actually, and they are trying to go, one step back, and then they want to come forward again later. So with this small introduction, I request all the participants to this sort of webinar rather, won't allow you to come on audio and speak. So I request you to all put your questions in the Q&A box that will be taken up by Dr. Krishna. Dr. Krishna is our moderator today. And you want to say something and comment throughout the session, you're welcome. Don't get bored. You can put anything, everything, your experiences in the chat box. That can also be picked up by Dr. Krishna. Questions in the Q&A box, and any chat, any message you want to put, that should be in the chat box. With this information, I hand over to Dr. Krishna, who is our coordinator, who is our moderator today. Over to you, Dr. Krishna.
Thank you, Vijay. Thanks for introducing me. I am the moderator for this session, and I'm thankful for the Tele Arogya to make me a moderator for rTMS especially. I and Vijay used to be in the UK, and we had met Professor Barker over there, I think in 2007, I believe. Isn't it, Vijay? And then I think that was quite fascinating at that point in time, because rTMS was slowly being introduced at that point in time. And later on, we, from 2010 to 15, we regularly attended the rTMS conference, and we met Professor George and others. So during that time itself, why I'm saying this is because of some context why we are talking about this. The reason is, at that time, it was thought that it is one of the treatment which is going to go on our mainstream. It is going to go mainstream, but it didn't happen till 2020. You might all know. Why is that? I think that's Dr. Murali is going to speak about that. We know that till now there are so many research has been happening. In last 3 years, there were more than 4,500 papers has been presented about rTMS, and more than 3,000 in last 3 years are based on depression. So many evidence are there, but still people are very reluctant to use. As a psychiatrist, we are quite not reluctant to use those technique. Why is that? It may be a lot of reason might be there. And I'm sure Professor Murali knows more about that. But why I'm saying this is to put in a context why we want this conference to happen, and we want to know how effective rTMS is. If some of the practitioners who are here knows who are already been practicing rTMS, they know that it can bring miracles to the patient. I would say almost like a miracle. You can see cognitive improvement happening, who are severely depressed, and some people with the schizophrenia with negative symptoms improving drastically with when you start using rTMS, and also on dementia. But people are still skeptical as of now. And I think, and that is the context which why we are at this point in time. Um, we are not using some effective treatment which is already available with us, and this can help us as well as the patient on a long term. And I think rTMS is going to go mainstream. It has not happened, but eventually it is going to go mainstream in next couple of years, or in a decades. It is going to happen. And and why we are talking about this is because the context is, because again I'm stating is because we are talking about effectiveness rTMS, so people understand why we are uh, why we are talking about rTMS. So let me introduce Professor Murali Rao. Then I will talk about. Then I will again introduce Dr. Vijay as we go along. Just I think most of them in Karnataka knows know who is Professor Murali is, because he has presented various papers and he is well-known person here. He has and he had I think I met him 1 year back when he came for Mindful TMS inauguration. Uh, he is professor of Loyola University, and he has more than 80 publications, especially in neuromodulation, uh, regarding neuromodulation, something like rTMS and other papers. He has also one book which has been published. I think its book is name is 50 plus, if I'm correct. I might be wrong as well. Sorry, 50 plus and dealing with life or something. So I think I need to read that. Not read. Sorry, sorry, Dr. Murali, if I'm misspelling it. And he's also director and founder of Neuromodulation Society of India. And Neuromodulation Society basically deals with rTMS and TDCS and other new emerging neurotechnologies. He is also founder for Society for Depression in India, which basically deals with improving life in the people with depression. So without ado, I just want to hand over my mic to Dr. Murali, so he can talk a bit more about effectiveness of rTMS and what context why we are talking about that. In the meanwhile, I will take about questions. If you are in question and answer box, whichever questions you are going to put that, I'm going to, and also in chat boxes, I'm going to take that questions. All right. So I will be taking up later on once both the speakers finish their talk. Okay. So without that, I'm handing over to Dr. Murali. Thank you very much. Thank you.
Thank you, Dr. Krishna. Thank you, the sponsors of the programs, the Tele Arogya and Mr. Ganeshan from Microlabs. I very much appreciate that itself answers one of Dr. Krishna's questions. Why it's not popular? Because people are not aware of it. And second thing is the cost. If those factors were removed, it would be as popular as anything else, because we know our as psychiatrists in the field for many years that we have psychotherapy and we have medications, a number of them, many of them are just me too drugs. So we keep on trying on poor depressed patients one after another. So the patient doctor relationship continues as long as the patient is alive or the doctor is alive. The reason is they don't improve significantly. Some are magically, they improve. That's only 1/3 of them. Other 2/3 are in limbo. They're neither getting better or don't want to get worse. So they are the ones who are constantly attending the psychiatrists and psychologists' offices. Luckily, for the first time in the hands of psychiatrists is available a tool, a procedure that they can do, which is non-invasive. And yes, it took a long time. I went to Dr. Mark George's lab in 2000 and interned with him when we were having a little magnet box that we were holding with calipers and steady hands over the patient's head. I mean, so it took 2008 when FDA first approved it. And this is, I'm not trying to say rTMS is the end of all, beginning of all, but this is the beginning of all for sure, because neuromodulation technologies are becoming more and more focused on understanding not psychiatric disorders as DSM-5 syndromes, but as uh, the symptom clusters related to brain circuitry. National Institute of Mental Health, about 4 years ago under Tom Insel, changed the policy that they will not support or fund one more monoamine antidepressant anymore. They have to show the link between the brain and the therapeutics. And until you demonstrate that, there is no funding. So that's another reason why there is so much of understanding, so much of focus on understanding the brain and its functioning, its structure. And we all know about genome project that finished well before time during Clinton, whereas the Connectome project is going on longer than it should have because the complexity of the brain. Okay. With that brief, let me start sharing my screen and start with my presentation. I don't know.
It's the same thing. It's just gone forward, I think. It's the same thing, sir. You can press backwards.
Just go back and that's it.
Okay, got it now. Okay. Sorry about this. Okay, so our understanding of depression has changed rapidly last 10 to 15 years. I'll show it by an example. If a question were to be asked in the psychiatric boards, the question being major depression is primarily due to abnormal function of noradrenergic, serotonergic, and dopaminergic neurotransmitter systems as a choice number one, not associated with volumetric abnormalities in any cortical or limbic structures as a second choice, the result of clear abnormal structure and function of the mammillary bodies as a third choice.
Professor Murali, you want to share the
Sir,
screen? Slides are not
sharing of
visible.
Screen
Oh,
sharing
really?
is not done.
Screen share, screen share.
Oh, sorry.
You've gone backwards, so you need to go one step forward again. Share screen. Share screen. It's at the bottom. It's at the bottom of your Zoom.
It's a green one.
Green color, yes.
One with an arrow mark.
Participants, Q&A, chat, share screen.
Fourth icon.
I
Bottom.
hit the share screen.
Share screen. Click on it, please. Yeah.
Are you seeing it?
We can see your desktop. You need to switch it on at the background, at the back of the screen.
Okay, got it.
Yeah.
Probably you can see it now.
Yeah. Okay, done.
Okay, these were the answers I was reading, and the last answer being all of the above. So about 5 years ago, we used to explain to our patients that their depression is because of quote and unquote chemical imbalance. That would be answer number one. And then number two is volumetric abnormalities. We didn't have neuroimaging findings. Now we know very well that untreated depression could be a precursor to dementia. And then the result of mammillary body is a structure that's not correct. So if the right answer actually is, it's a result of systems level dysregulation of multiple cortical, subcortical, and limbic neurocircuits. So it's not a secret anymore. Finally, psychiatrists got an organ. It's not the heart, it's not the feelings in the gut feelings and broken heart. The brain is the seat of all behavior problems and psychiatric issues. So it's all in the circuitry in the brain. Um, to further say one more word here is that psychologists may feel left out, that you're all too biological and everything you relate to something happening in the brain. And uh, it's a fact that the patients who do benefit from, let's say, CBT or interpersonal psychotherapy alone for the major depression do also show the changes in neurocircuitry in the brain. So it's not like one treatment is better over the other. It's finding the right treatment for the right patient. The personalized psychiatry is the key, because the effect, whether it's ECT, medications, TMS, magnetic seizure therapy, psychotherapy, those who respond extremely well, their baseline to after treatment circuitry analysis by fMRI and circuitry mapping clearly shows there is change. So anything that works that system, it will be the treatment. So going back, I mean, in psychiatry, as most of you know, that it started with a neuromodulation way before psychopharmacology. It was 1938, it was CCT, then Dr. Penfield and Maxwell. Then here is Dr. Barker in his early years when he was trying that in Sheffield. Yes, and then he came to the Royal College and opened his closely held to his chest secret of 17 years working from his basement. When he announced in the Royal College of Neurology in London, he opened the box and showed, now I have the neuromodulation equipment. Everybody got excited, and that excitement took a long time before it became an actual thing, because US FDA particularly wanted this to be done on 10,000 patients and should be purely evidence-based. And they had to see the evidence before they approved it. That's why it took a long time. Now, one of the most famous Nobel Prize winners, authors, and American icon, Ernest Hemingway, had severe depression. He actually lives in the same neighborhood that I live here in Oak Park. He was born and brought up here, and traveled around. Because of depression, those days only ECT was available. So he got lots and lots of ECT, about 8 rounds of ECT. So he said, being an author, a novelist, and a thinker, what's the sense of ruining my head and erasing my memory, which is my capital, and putting it out of business? It was a brilliant cure, but we lost the patient. We really lost the patient. He committed suicide finally. So if you look at, like Dr. Krishna mentioned, the literature in the last, I just reviewed for 18 months, there were at least 10 issues dedicated towards neurocircuitry in biological psychiatry. Like here are some of the covers, and you can see obsessive compulsive disorder and corticostriatal plasticity, cannabinoids, ketamine, connectivity and depression, mechanism, depression, antidepressant treatment with TMS. So it's being researched for accuracy and personalization now more than ever. And actually, the latest discovery was in University of Toronto that if you do the baseline mapping and looked at subsequent total responders, there was a pattern detectable which could predict with 99% accuracy if people who had this connectivity pattern as a part of major depression, they are the ones who would respond to TMS. I wish that goes further to decide who will be the candidates for CBT, who will be the candidates for psychopharmacology. Then we can be specifically addressing each patient's problem instead of throwing everything at everyone. That's what we currently do. So, as Vijay said, yes, the coil, the figure eight coil or circular coil, or whatever kind of coil you're using, is letting the circuitry, electric circuit run in circles, but it won't reach the patient at all. So that's why it's very, very safe. Whereas, as we know from Faraday principle, the perpendicular to the axis of the coil is the magnetic waves, which has no obstruction at all. It penetrates through the skull like nothing, no barrier at all, and activates particularly the gyri in the corners where it's taking a bend. They've studied including the micro electrodes into these, and they see the maximum depolarization happens where the neurons are taking a bend. So now the TMS has advanced to focus on the corner of the gyri instead of the middle of the gyri, which 10 more percent of higher yield. Okay, that's possible with neuronavigation. Of course, in mindful TMS, we do develop neuronavigation targets, and then we transfer to the facilities for targeting based upon 1020 EEG system. So with pretty much accuracy. But here in all US centers, we are doing neuronavigated method only. So of all the available neurostimulation technologies, there are two that are non-invasive, and one is TMS, one is TDCS. One is magnetic, one is electrical. Both are non-invasive. But unfortunately, TDCS, with in spite of number of attempts with FDA, have not been able to get an approval because they have not been able to show evidence-based recovery. There's only case studies and stuff like that. Whereas TMS stands to be the only neuromodulation technology available at this time. And perhaps very soon, Dr. Holly Lisenberg, who is the chief of neuromodulation, director of neuromodulation studies at NIMH, is working, carried over her work from Duke on magnetic seizure therapy, where you will have seizure treatment, but without loss of memory. So that could be coming up in a year or two. So what's the net effect? I mean, we have seen it was the level of neurotransmitters, but as we have learned depression more and more, ultimately, especially since the advent of ketamine, we learned for the first time that the brain neurons in hippocampus in 4 hours can sprout dendrites, which is amazing. We thought after age 21, you have nothing but to lose your neurons and the connections, but that's not true. At any age, ketamine proved it to be totally different. It's been an eye opener for us. So it increases the neurogenesis in hippocampus. Ketamine takes 4 hours, whereas antidepressant takes 6 weeks or longer or sooner. So that's why there's so much of delay from the onset of treatment to the onset of benefits. So this is the current standing from the World Federation on Guidelines of Brain Stimulation Treatments, also Canadian Network for Mood and Anxiety, American Psychiatric Association. So the thing has changed so much. It used to be failure of 4 completed sufficient treatments with antidepressants, then only they would be eligible for TMS. So it has changed over the years, and the latest one from FDA guideline is 1 successful completion of trial with an antidepressant is enough before you can try TMS, because earlier you introduce TMS, better it is, because treatment resistance, as you know from STAR studies, gets progressively worse with repeated treatments. So earlier you introduce it, it's better. So now insurance companies are also slowly seeing the benefit of this. And I think about 2, 3 weeks ago, first time the California Anthem Insurance, which is Blue Cross Blue Shield counterpart, they now authorize use of TMS with only 2 treatment failures. And so that is the current recommendations. So it has come at this day and age. If we are dealing with the depressed patients, if we do not offer all the options available like psychotherapy, medications, and TMS, I think we are not doing justice, because some are not doing it, some are not even aware of that. Like Dr. Krishna pointed out, that's very true. In my own department, my senior professors send the TMS patients for TMS therapy at all. Then, whereas the younger ones, all my residents who have become subsequently the junior faculty, since they had TMS in the training, they saw the benefit firsthand. They routinely use it. So it depends on when you got trained and how advanced, how much have you kept up with the literature. Well, that's our good old Anthony Barker, man with a lot of sprite, and he was invited for the first assembly of Clinical TMS Society in US. And I was on the first board of council, so I had the opportunity to meet with all the great people, and through Mark George, of course, who is my mentor, and then met with Barker. And he keeps on with the topic and keeps reading about it, and is quite up to date in spite of his age. And he shares his funny experiences. It was a wonderful event. So this was our old thing, the neurotransmitter, norepinephrine mostly works on energy, serotonin on impulse, drive is from dopamine, the overlapping areas that affects our anxiety, motivation. And then came the pain, became one of the issues. That drugs that work on both dual acting ones are helpful in pain because they follow the same neurotransmitter pathways in the brain. So this was our understanding. Now our thinking has changed in an evolutionary way from neurotransmitter to neuromodulation. So if you see, there are vagal nerve stimulation, which is highly invasive. It's very hard to get a consenting patient to have a surgery for the depression. Magnetic seizure therapy, of course, to replace ECT to get rid of the cognitive issues. TDCS still yet to prove its efficacy. So the only thing that's been approved and be shown to be efficacious has been repetitive transcranial magnetic stimulation, which from 2008 gradually has acquired additional indications as more people are using. Currently, there are about 700 treatment centers in US offering TMS, and more than 2 million treatments have been delivered. So now we have much better understanding that about 10 to 15% of patients do relapse. They may need maintenance TMS. Others do not, as though their brain was reset once for all. So it has gone. Now we got clear indication for OCD, bipolar depression, in addition to major depressive disorders. And there is a lot of evidence from the VA psychiatry in post-traumatic stress disorder. And I'm in fact, I'm fortunate to be participating in a National Institute of Health study at Duke on prevention of dementia by using transcranial magnetic stimulation in those with mild cognitive impairment. It's a 3-year-long studies. We just ended recruiting 58 patients. So the results will be out in 2023. We are using either sham or real rTMS to see whether it slows down the early dementia process in the brain. And definitely it does work in Parkinson's. Uh, like, patients walking out of TMS are not rigid, don't have the heart and proceed kind of thing. But unfortunately, it's short living. So to prolong the effect is the current research. And stroke rehabilitation is routinely being used at Duke and at Harvard. So patients, before they go for their physical therapy, they get the TMS to remove the suppression of the intact hemisphere of the brain on to the stroke side of the hemisphere. So by releasing that inhibition, patients can make best use of their rehab and recover faster. Um, Smoking cessation just got approval again for the deep brain stimulation that was within the last month. So it's gradually gaining momentum with more specificity and accuracy. So this whole thinking started with Helen Mayberg of University of Toronto, who had this seminal paper where she clearly demonstrated severely depressed patients have increased brain glucose consumption, oxygen utilization in the subgenual area 24, area 25, and then decreased glucose consumption and uh, oxygen consumption in the dorsolateral prefrontal cortex, that is area 24, Broadman area. So there was this, the negative mood state was coming because of the reversal of this. And then this was further confirmed by people who did the connectivity mapping. This may look very complex, but it's very simple if you understand. So for us dealing with neuropsychiatry, there are about 16 salient networks of importance to us, even though there are thousands of networks in the brain. I'm talking about functional connectivity networks. They are not necessarily adjacent, but they're connected through the white matter, through the, like, for example, the default network, which is always active, even though default it's once thinking goes that it should be calm, and no, it's actually brain is firing all over the place. Only when you do something, pay attention to it, then it start focusing all the efforts to that one area. So there is this dorsal attention network, there is ventral attention network, and there is affective network, very important to us, and the default network and the frontoparietal network. These five are clearly shown. Wherever you see the white arrows, that means there is increased connectivity between frontoparietal network and default network. And similarly, there's a decreased connectivity between default network and the affective network, and so also between the frontoparietal network and the attention network. Now we can understand, like in math, that the connectivity changes is what makes the amygdala sitting right next. So why we find 75 to 80% of depression patients also have anxiety because of the um, hyperconnectivity to those regions. Like if you look at this another diagram, this is supposed to be the normal functional connectivity of the areas of significance for us. This is amygdala, rostral and dorsal cingulate cortex and the dorsal prefrontal cortex. Here, this is the normal. The arrows show the connectivity being strong, strong and equal between all these structures. As you see in major depression, this connectivity is weakened, and this connectivity has become excessively stronger. So also this one. So these are consistent findings, regardless of whatever theory of depression. This is the actual connectivity maps studied in the brain. So if we can recognize this gentleman, is Mr. Tesla. So the unit of measure in the magnetic fields. So even he, in his earlier finding had a good understanding. He said, my brain is only a receiver. In the universe, there is a core from which we obtain knowledge, strength, and inspiration. I have not penetrated into the secrets of core, but I know that it exists. So what he predicted then is now becoming gradually realized. So some may say, the TMS only has a penetration of 2 centimeters, how it can reach all parts of the brain and, deeper structures where the emotions are regulated. So this is a good EEG done inside this TMS, under the TMS coil. You can see the yellow cross is where the TMS is delivered, but you can see the exact opposite side of the brain because of the transcallosal strong connectivity in the brain, get the equal impact. Yellow shows the highest point of heat. So you can see it equally reaches the other part. So there's even though only 2 centimeters depth, but it has got connectivity because there's so many neurons. It can tickle your finger and toes. So it through interneuronal connectivity, it goes much deeper and much farther. Now, this is circuitry involved, um, as we know in the OCD, the Fronto-Striato-Thalamo-Frontal Circuit. So now the thing is, since it was all deep-seated, there was no access point to reach into the circuitry. But now the TMS has changed to using stimulation through the frontal poles to reach this area and reach the circuitry. You can approach the circuitry from wherever you can. The effect will be the same. But as you can see, the access points are very difficult. Luckily, the frontal approach, and now the new coil that was just released 3 weeks ago, approved by FDA, which has able to go to the frontomedial parts of the cortex, will be, this is the one that's been approved, just like the deep TMS coil, for smoking cessation. So you can easily understand, since we can reach the ventral tegmental area, there's a lot of opportunities in dealing with lots of addiction. That's the fascinating field. The more recent papers are all about cocaine and opiate addiction, smoking cessation, it got approved, eating disorders, gambling, sexual disorders, hypersexuality. So it's limitless now that you can reach the circuitry involved. So in near future, we'll be reading, there's actually a lot of literature on addictions and the efficacy of TMS. This is what I was talking to you about. You can reach the deeper parts of the brain through the frontal targets. So you can do a prefrontal theta burst. Actually, these treatments are not tedious like in depression. This is a 7-day treatment, twice a day for 7 days. And the treatment duration is only 3 minutes because you're using prefrontal theta burst. And it can target deeply because of this connectivity. So we started out with ECT in 1938 as the first psychiatric treatment ever. Then it's been psychotherapies of all kinds, starting with psychoanalysis to every other kind that we have. There are more than 300 kinds. Only 2 have been considered to be proven for its effectiveness in depression: CBT, interpersonal psychotherapy. And of course, pharmacotherapy has been the mainstay. And now we have the third option, the neuromodulation therapy. And this has got unprecedented therapeutic potential as we go forward. I think this is the cutting edge. And since I got excited about this in 2000 when I did internship with Dr. Mark George, I see the progress, and I am, therefore you see my excitement in this. So let's, I want to close with Bill Gates' famous observation. We always overestimate the change that will occur in the next 2 years, but underestimate the change that will occur in next 10. So we are short-sighted. So if you keep the long sight, things that can this is just the beginning. I mean, this is first time there's a tool in neuropsychiatry that's been used only sparingly because the cost and the equipment cost and the training and the knowledge part, but it's going to be going to places uh, if you give next 5 to 10 years. So now this is just a summary slide to say that there's a third option. Traditionally, it's CBT or one of the antidepressants, and you could keep on changing, not taking the exit, or you can take the exit at an early point. So give a patient an opportunity to recover sooner. Again, it's not the panacea, everybody won't recover, but you're increasing the chances from 33% to 60 to 65%, depending on how accurately you do the treatment and how good you are as a therapist to keep the patient in treatment for 30 sessions. It's not an easy job. They have to come regularly for 30 sessions. Then only they see the total benefit. Um, so we have been able to see that because thanks to the insurance companies that authorize us to use 36 treatments, 30 actual treatments, 6 tapering sessions. And now it's become a standard practice that it is approved almost by all insurance companies with sufficient evidence that there's a right diagnosis and the treatment failures well established. So this is all my references. And at this point, I will stop so that I can later on take questions from the audience. And thanks for listening to me.
I thank Dr. Murali uh, for giving us a wonderful overview of rTMS, and we see that there's a lot of future improvements are going to happen in the field of rTMS and other neuromodulation. Plus, also we will be knowing more areas where we can stimulate our brain so that we tend to improve upon the outcome of rTMS. I think that's the more important. We want all us to know that now how much is the rTMS treatment. It's not about the treatment per se, it is about the outcome or how effective it is. And as we are moving ahead, I think with the rTMS, we will be having more outcomes for more various disorders as well. Now, in terms of smoking, we got to know now. I think there's also research going on ADHD as well, which FDA is going to approve. I don't know, it's maybe this year or the next year, FDA might going to approve for ADHD as well. So I think rTMS future seems to be quite bright. And I think we are only at only scratching the tip of the iceberg, I think, at this point in time. I hope, and I think there are lots of questions I will take up later. And before, I think I will go for the next speaker. He is Dr. Vijay. He's the director at Mind rTMS at Bangalore. And I would just a brief introduction. He did his MBBS from Mysore Medical College, and later on he did his MD Psychiatry from Central Institute of Psychiatry at Ranchi. He has various papers to his he has presented various papers, and he also trained in neuropsychiatry, epilepsy, EEG, and sleep disorders. His main training are all based on neuromodulation. I think that's why he is quite interested in these fields. And he is also a member of Alzheimer's and related disorders, as well as Indian Psychiatric Society. And without talking much about that, I will hand over it to Dr. Vijay. He will be briefly explaining about rTMS, and I think there is also some videos which he is going to present to us, just for us to know how rTMS works. For some people who are here who doesn't know how rTMS works or how safe it is, perhaps they can watch those videos and they can understand that. So, and also I asked other participants to put your questions in the chat box, please, so that I can take up the question with Dr. Murali and as well as with Dr. Vijay Mehti. And handing over to Dr. Vijay, please. Thank you.
Thank you, sir. Thanks a lot for your introduction. And I would also like to thank Dr. Murali for his wonderful talk. So now I think we'll be playing a small video. Presentation and then the So now I'll be talking a little bit about the practical aspects of TMS. I hope my slides are visible. Okay. So a lot has been told about what is rTMS, how it works and all. So I'd like to skip that. Just to mention, it's a focal application of localized pulse magnetic field to the cerebral cortex, which subsequently induces small electric currents, which later on stimulate the underlying neurons. When stimulated, it causes neurons to fire with the aim of altering brain function for therapeutic purpose. As explained before, it is completely non-invasive with the minimal risk. The only risk is that seizures, which we'll talk about a little later on. So, what are the conditions or when is TMS supposed to be given? It should be administered where there is adequate evidence of clinical indication and effectiveness. So some of the condition in which there is established evidence of effectiveness is depressive disorders, schizophrenia, OCD, and others. So particularly my discussion will center around depression. There have been over 30 randomized controlled trials involving at least a placebo-controlled study, which demonstrate efficiency of TMS in depression to a rate of about 50. So TMS can be considered an effective treatment for depression with level 1 evidence. So in schizophrenia, the level of evidence is less substantiative than that for depression. The target areas are auditory hallucinations, negative symptoms of schizophrenia, and cognitive deficits associated. There There is a definitive evidence of efficacy for rTMS as a treatment for auditory hallucinations. In OCD, the recent evidence supporting the effectiveness of TMS in OCD is increasing, and there have been a wide variety of treatment targets targeting orbitofrontal cortex, left DLPFC, right DLPFC, supplementary motor area, pre-SMA. So there have been a wide number of areas of brain which have been targeted for treating OCD. The optimal targets and parameters remain undefined. In 2018, US FDA approved deep TMS for OCD. So in deep TMS is a different kind of call, what we call a sketch call, which is used which has got deeper penetration. Some of the other conditions in which TMS are considered as post-traumatic stress disorder, autism spectrum disorders, substance use disorders, tinnitus, and chronic pain conditions. Given the nature of research which is being carried out, the range of application for rTMS has been changing, and down the line we can see that more disorders add on for use of TMS. So coming to patient selection, the patient selection and screening is usually done by a psychiatrist. The person who administers TMS or prescribes TMS should be adequately trained and should have a detailed understanding of when TMS is clinically indicated and when contraindicated. For any case, the risk-benefit ratio has to be considered carefully, and during the process of TMS, a periodic evaluation of these risks has to be done. There are some conditions like in pregnancy, there is little safety data on use of rTMS in pregnant women. Theoretically speaking, the risk of rTMS is pretty low. Again, coming back to child and adolescent population, there is little safety and efficacy data. It has to be considered where there are limited other treatment options available, and the potential clinical benefit should outweigh the risk of treatment in this group. The risk which is associated with TMS is seizures. Though we say seizures is one of the known adverse effects of TMS, the risk is very, very low. If adequate precaution has been taken, if adequate assessment has been done for finding out the risk factor for seizures, the possibility of seizures can be reduced significantly. In elderly, again, the studies are limited. It has been seen that the antidepressant efficacy of rTMS is not necessarily reduced in older patients. It's not that TMS doesn't work in elderly people also. It's been shown that TMS has got similar kind of antidepressant effect in comparison to adults. And there are no additional safety concerns to be worried about. So coming to the clinical setting, it is an outpatient procedure where the patient can come, take the treatment, and then leave immediately. There is no need for the patient to rest, or there is absolutely no need for the patient to get admitted. It does not require any kind of sedation or anesthesia. This should be the proper treatment protocol has to be set in place, okay, which includes at least patient assessment, monitoring of the patient during the course of the treatment, have a proper protocol for assessment of possible adverse events and the outcomes. So there are various manufacturers of TMS. Okay, it's better that to have a TMS which has been approved by a particular accreditation agency, like for example US FDA. When we start TMS, there are certain variables, certain parameters which needs to be considered. First and foremost, the stimulation side. We see that it's the left DLPFC, left dorsolateral prefrontal cortex is the most commonly used area site of interest for particularly for psychiatrists. Then there are other sites like the right DLPFC, and then the Heschel's gyrus for auditory hallucinations in schizophrenia, the orbitofrontal cortex, SMA or pre-SMA in terms of OCD. So these are some of the commonest site which we use for relation with TMS. It depends on person to person. It also depends on the disorder for which you are treating. Next is frequency. So frequency of TMS can be all the way from 1 hertz to 50 hertz. We usually see that anything over 1 hertz is stimulatory and anything less than 1 hertz is inhibitory. Okay. Then the intensity of a magnetic pulses which needs to be delivered. The frequency of treatment sessions, number of stimulation pulses or trains applied per session. Okay, so all these things has to be considered before going ahead with TMS. So coming to depression, we have level 1 evidence, which means to say that there is definitive evidence for efficacy of TMS in case of depression. Some of the target regions of depression is high frequency stimulation applied over left DLPFC. When I mean to say high frequency, generally 10 hertz frequency is used. The other potential use is low frequency stimulation applied to the right DLPFC. Low frequency means 1. There is also a possibility of sequential bilateral rTMS where we do it both on the left as well as the right side. And then there is deep rTMS which has shown efficacy in treatment depression. There is also theta burst which has been explained by Dr. Murali. Then motor threshold. So first and foremost, we try to find out the motor threshold. That is the minimum possible intensity of the magnetic current by which we can elicit a response. When I mean to say response, is usually we see a twitch, okay, in the right hand. So based on this motor threshold, the lowest possible intensity at which the patient responds, we determine at what intensity the magnetic stimulation has to be given. Like for example, in case of depression, we give it at 120% of the motor threshold. There are some disorders in which we give it at 100% or sometimes even lesser than that, sometimes around 80 to 90%. Coming to coil placement, there are various methods of identifying the region for coil placement. Okay, let's say in case of left DLPFC, there is a modified 5 centimeter rule in which we try to find out the motor hotspot where we find a motor threshold, and when we move ahead by 5 centimeter anterior to that in the parasolital line. This is one mode of finding out where exactly is the DLPFC. Apart from this, there are other modes also, but you can also make use of neuronavigation method where you can exactly pinpoint and say where exactly is the DLPFC. Then there is targeting based on 1020 EEG system like the beam method, where you try to find out the region by entering certain parameters inside a software like the head circumference, anterior posterior distance, and the transverse distance, which gives you a couple of parameters. Based on that, you can calculate where exactly is the DLPFC. Coming to scheduling, usually what most centers follow is single session on a daily basis. Typically, what is followed is 5 sessions per day, so that we start from Monday to Friday and take a break on Saturday and Sunday. And the total duration is for about 4 to 6, which roughly translates to around 20 to 30 sessions. Apart from this, there are also auxiliary protocols in which more than one session can be delivered, with some time interview about 45 minutes to 1 hour in between. There have been studies which are coming up where there are about 5 sessions being given in a single day for about 5 weeks. Okay? So any protocol which uses more than one session per day, we refer it as accelerated protocol. So assessment is there is no specific preparation as such. Okay, usually a full psychiatric evaluation, routinely what you do that is done. Then the medication review is done so that if there are any medications which affects the TMS treatment, or if there are any medications which tends to change the seizure threshold, those medication review will be done. Then there is a detailed assessment for evaluation of risk for seizures, and also the risk for treatment emergent affective switching is being taken care of, where we take into consideration history of any prior antidepressant induced switch into consideration. During treatment, there is a continued periodic assessment in terms of like risk effect, the risk involved, the adverse effects, the progress of treatment. We usually tend to make use of psychiatric rating scales so that our treatment can be monitored, can be progressed. There has to be facilities to manage complications, including seizures. There has to be proper protocol set up, okay? And you need to identify signs of any emergent meaning switch during the treatment. There is also this concept of maintenance TMS, where there is a lot of research being done. There are various protocols which we use, like let's say there are a couple of sessions given in a month, then it's given in bursts, like let's say monthly, about 4 to 6 sessions. So it varies. So coming to evidence, this is a wonderful review which is done very recently, where we see that there is level A evidence of definitive efficacy for some disorders, out of which depression is one. Apart from that, there is also definitive evidence for efficacy in terms of like treatment of neuropathic pain, okay, and in terms of like hand motor recovery in post-acute stage of stroke. So these are some of the conditions, non-psychiatric conditions in which TMS has seen to be definitely efficacious. There is level B evidence for other disorders like fibromyalgia, okay. Then in Parkinson's, improvement of motor functions, improvement of cognitive functions in Parkinson's. Then also to reduce limb spasticity in multiple sclerosis. There is also probable efficacy reported in terms of PTSD, non-fluent aphasia, okay. Then other treatment protocols for depression. Okay. So with this, I would like to show a small demonstration about how TMS is done.
At Mindful TMS Neurocare, we have a treatment plan that includes both TMS and psychotherapy administered simultaneously. Research shows that providing psychotherapy during TMS treatment improves the efficacy of the treatment. We have consistent knowledge sharing sessions between our US clinics and clinics in India to ensure our protocols are in line with the best TMS protocols in the world. At Mindful TMS, we ensure the latest coils are available with us the minute it is released and approved by the US FDA. For instance, we have the newest coil for treating OCD post US FDA approvals. The chair for TMS is essential. We at Mindful TMS have chosen to import the original chair as against fabricating one locally in India.
Hello everyone, I'm Dr. Vijay Maitri. I'm psychiatrist practicing at Mindful TMS Neurocare, Bangalore. So today I'll be giving a small demonstration about what TMS is about. So this is a typical standard TMS setup, okay? So preferably it's an convenient room, not that crowded, and preferably where there are no other patients. This is a very typical setup which is used for TMS. Now, TMS, the machine per se, has got a few components. This is the couch, okay, on which the client is made to sit comfortably. So the couch can be adjusted as per the person's convenience, as per the person's comfort level. Okay, we can recline it, we can adjust the height. This is the couch. This, what you see over here, this is the main stimulator in which there are all the details of the TMS, including the protocol, settings, and all those things. Apart from this, there are also a couple of components, which is mainly one you can see that it's the liquid which is used to cool the coil so that the coil doesn't get heated up. And then there's another vacuum for the pillow. What you see over is the pillow, so that during the treatment procedure, the person's head and neck is stabilized so that the movement is restricted. Now, this is a coil which is used for TMS. As you can see, there are various coils available. Okay, this is a typical figure of 8 coil. Okay, this is an oil-cooled one. If I had to mention it, this is a B65 coil. Okay, which we use for the treatment. This usually sits over here. Okay, and this stand is mobile, so that once we decide where exact location, what is the exact location where it has to be placed, so that it can be placed in that particular area and then it can be locked, so that you do not have to keep on holding the coil during the entire treatment process. This is one more coil which has the advantage of being lightweight, okay, which can be easily manipulated. We use it for detecting the motor threshold initially. So before starting the treatment per se, we usually do a protocol evaluation. Okay, we do a complete psychiatric assessment. And if the person requires TMS, then we go ahead with TMS. Of course, consent is one thing which has to be taken. But the most important thing is assessment for any risk, particularly risk for seizures. So we have a protocol, we have a pre-treatment assessment which we consider. And once everything is fine, there are no contraindications for a person to go ahead with TMS treatment, then we start the treatment process. There are certain protocols which we follow. Protocol for TMS, what we follow is US FDA approved. Apart from the protocol, the manufacturer of TMS machines, including coil, they have also got US FDA approval. The manufacturer, what we use is MagVenture. MagVenture is US FDA approved. So now I'll be providing a demonstration with a virtual patient. So this is how the client is made to sit on the couch, and we can adjust it according to their comfort level. Okay, so I'll be adjusting the seat. Let me know if that's comfortable. Okay, so you can recline it. You have the provision to lift the leg. We assume that a detailed evaluation, psychiatric evaluation has been done, the protocol has been followed, and then subsequently we are moving ahead with the treatment per se. This is the cap which we'll be choosing so that we can do the relevant markings, and the same cap can be used for the subsequent sessions so that we do not have to keep on marking on each and every session. So you can put it from the front in such a way that it's in the midline. You have a marking over here, so that is exactly where it should correspond to the midline, and you can follow a particular standard. You place the cap just above the eyebrows. Okay, it has to be ensured that the cap is placed in that particular position during the rest of the treatment sessions, and the cap is firmly placed over the client's scalp. So we do have the option of writing the patient's initials or name over here and along with other details including motor threshold. Once this has been done, our next task is finding the motor threshold. So before finding the motor threshold, there are certain measurements which we need to make. First and foremost, we need to find the CZ region. So this is the measuring tape what we use. First and foremost, we try to find out the distance between the nasion and the inion. Nasion is this part at the root of the nasal bridge, and inion is the lowest point on the occipital protuberance. So you can have a marker pen so that you can mark. So now I'll be measuring the distance from nasion to inion. Okay, so here is somewhere here lies the inion. So it is just, it's 36 centimeters. Okay, so at the midpoint, that is 18 centimeter, I make a mark over here. Okay, you can extend the line. Okay? You can make a mark. The next is distance from tragus to tragus. Just a minute. Okay. You can see the tragus over here. It's 38 centimeters. Half of it is 19 centimeters. So I make a mark over here. So the intersection of these 2 points, the intersection of the distance between nasion to inion and from tragus to tragus, the intersection what you get, that is CZ. It corresponds to the CZ position of 1020 system of electrode placement. For the sake of identification, you can write the patient's ID. It will be the patient's initials or number, whatever it is. Okay, and just mark it as R. Okay. So now we have marked this particular point, which is CZ. Next task is to find out where the motor threshold or motor hotspot is. For this, we will be using this coil, which is portable. Okay, so it's a pretty handy coil. It's a typical figure of 8 coil which we'll be using. So you can select the intensity arbitrarily somewhere around, let's say 50 or 60. Okay, since we have a client who is healthy adult without any contraindication for TMS, we can start from 50. So we can tell the client that what we'll be doing. Okay, we can just tell them that we'll be giving stimulus over here and what they can expect so that they do not panic. So typically a stimulus, this is the kind of sound which you'll get. Okay, and it's not going to be painful. Okay, it could be a gentle tap kind of thing, and if it's distressing, please let me know. Okay. So typically the motor hotspot is found somewhere 5 centimeters lateral to the CZ point. It may vary, it may be a little bit anterior, it may be posterior, it may be a little bit more further to the lateral, but typically that is where you find out. Okay, so what you can do is that you can place the coil roughly about 5 centimeter lateral to the CZ. Okay, tell the patient to keep their arms on the armrest. Can you put on your arms over here? Even that also a little bit further. So for motor threshold, there's one more option where you can put the electromyogram on the right thumb so that you can see the activity of abductor pollicis longus. Okay, so we don't have that over here. So we'll be observing for the twitch in the right hand, preferably the right thumb. Okay. So I'll be giving the twitch. Okay, let me know if it's uncomfortable. So as I told you, 5 centimeter to the left of CZ. Now I'll start at intensity somewhere around 50. This is something which is arbitrarily selected. So when you give the twitch, you need to observe the right hand for any movements. Okay. So once you're not able to find out on that location, you can move around. Okay, you can move around. So I'll just move it a little bit to the lateral. Yeah, now we can see there's a small twitch. Okay. Okay. So pretty consistently, we are finding the twitch. Make sure that the stimulus is not given in quick succession. There has to be time lag between 2 stimulus. Okay, so this is where the motor hotspot is. I'll make a marking over here so that I do not lose it. Okay. We have found out a motor hotspot. Now, motor threshold is the minimum possible intensity at which you find a twitch. There is a certain protocol which dictates that out of 10 twitches, at least out of 10 stimulus, there has to be at least 5 responses. So let's find out her motor threshold. Okay. So she's definitely responding at 50. Let's decrease it to 45 also. Okay, so at 45, we're not seeing a response. I'll go with 48. So with 48, you will find very faint twitch, okay, and that too, it's not very consistent. Go back to 50. Okay, we see a small faint twitch in the right thumb. Okay, so out of 10 stimulus, we found a response in at least more than 5 stimulus. So 50 is going to be her motor threshold. So just we do not lose track of it, okay. I'll just mark it as 50 over here. So now that we have found out the motor hotspot and the motor threshold, next task is placement of the call. So the placement of the call depends on what protocol you use and the nature of the MS. Let's go ahead with placement over the left DLPFC, left dorsolateral prefrontal cortex, which is the commonly stimulated site for depression. Now, there are various methods for finding out for localization of left DLPFC. What we'll be using the 5 centimeter method, okay? Where once you found the motor hotspot, you need to go ahead 5 centimeter anterior to this spot in the parasagittal line. Okay. 5 centimeter anterior to this in the parasagittal line. This is where you'll be having the marking for left dorsolateral prefrontal cortex. Similarly, just in case if you have to do it on the right side, this is going to be the mirror image of this point, or you can find out motor threshold on the right side and then subsequently move further ahead by 5 centimeter. Now we have found out the motor threshold, the motor hotspot, the motor threshold which is 50% in this present client's case. We have marked the left DLPFC, and now we'll go ahead with the position of the coil. So we change the coil over here. We switch from the probe to the treatment coil. So this is a treatment coil which we use. Okay. So make sure that it is firmly fixed to the stand. Now what we have to do is that we need to stabilize the person's head and neck. Okay. Yeah. So now just to stabilize the person's head and neck, what we do is that we place this pillow. Okay. So is this comfortable? So then subsequently I inflate the pillow. So during the process of treatment, the person is free to move around with a little bit with the hands, legs and all those things. The person can also talk, but it's advised not to move head and neck. I'll place the coil over the marking of left DLPFC. A couple of things which you need to consider is that the intensity of the magnetic pulses are maximum at the center of the coil. So it's very important that when we place the coil, this particular center of the coil has to be touching the person's scalp. So it should be touching in such a way that it is not causing too much of pressure, nor it's too loose. Okay. So this is the center of the coil. So you can move around this lever. So some people usually say that it has to be angled at 45 degrees. Okay, if you want, you can follow that. Once the coil is placed, you can tighten it. This is one precaution where you have to take. Make sure that the center part of the coil is in touch with the person's scalp. Okay, this appears to be good enough. Now that we have placed the coil, okay, we are good to go ahead with the treatment. We have placed the coil. Okay, let's set the parameter. So if you see the stimulator, you will find a screen over here. In this screen, there are various parameters. There are various keys which you find over here. Let's say this knob, it's for selection. Okay, these are the arrow keys. And here there are certain buttons. Okay, so these are navigation menus where you can go to the main menu, configuration menu, protocol menu. Okay? So this is something which tends to set the intensity. before setting intensity, this is the button where you can enable the call. So you do have the option of enabling and disabling the call. Okay. So for the sake of setting intensity, this knob is used. Now coming to protocol, there are various protocols which have been used. I'll just demonstrate one particular protocol. If you see the screen over here, there are a set of parameters. Timing control, repetition rate, which is nothing but the frequency, pulses in train, number of trains, intertrain interval, okay, and then a couple of other options like option of ramp up of trains and warning sound. Okay, so this is where you can set the intensity of frequency, okay, starting from as low as 0.1 hertz or 0.1 pulses per second to all the way up to 30 pulses per second. Let's set it to somewhere around 10 pulses per second. So that is 10 hertz. Next, you have to select pulses in train. Okay, so each in protocol, what we choose is based on the previous level of evidence what we have. So let me choose pulses in train to somewhere around 40. Okay, then next you can choose number of trains. So let me keep it at 75. Okay, then intertrain interval, the interval between two train. Okay, I will set it as 11 seconds. So this particular protocol, what I'm using, where the repetition rate or frequency is 10 pulses per second or 10 hertz, the pulses in train is 40, okay, and the number of trains is 75, and intertrain interval is 11. This is the US FDA approved protocol for depression. Okay, so once we select the parameters, next what we do is that we tend to enable the call. Okay, now the call is enabled, and based on the prefixed intensity, the motor threshold what we get, usually the protocol dictates that it has to be 120% of the motor threshold. Now let's assume the motor threshold is somewhere around 50%. Okay, so 120% of 50% will be 60. So this is the treatment intensity what we use. Now I have set the intensity, I have set the protocol. Next thing is that I'll be starting the treatment. So this is how it is going to be. Once the treatment procedure has started, you can see the time elapsed to total percentage of treatment which has been done and the total duration of time. This particular protocol what I'm using, it delivers a total of 300 pulses per session, and the treatment session lasts for about 19 minutes. In between the process, let's say the person moves his or her head and you need to take a pause. You can pause it, you can pause the treatment, and subsequently once the setting has been done, you can again resume the treatment. So for time being, I'll stop it now. Apart from this, once you have set the protocol, you have set the parameters, there is also an option of saving the protocol, so that when the same patient comes to you for the subsequent sessions, you do not have to set the protocol each and every time. Okay? So we have that option. Okay? If you see over here, there are certain protocols which are already saved. So in this way, you can save the protocol and subsequently you can keep on using the same settings without entering the parameters each and every time. So with that, I conclude my topic, and I would like to hand it over to the moderator so that we can have further questions and discussions. Thank you.
Thank you, Vijay, for the wonderful presentation as well as for your nice video, which took in a detailed presentation of how it is done and how much sessions you take. I think it's quite detailed, and thanks for that. I think we will take a questions now because we don't have much time left. There are, I think, many questions has been already answered at the chart itself at Q&A. So I'm just going to ask certain questions which are still pending. Something like is rTMS can be used adjunct with SSRI for anxiety disorder? Yeah, anyone can answer. Even Dr. Murali can answer or Dr. Vijay can answer.
Absolutely. Actually, most of the TMS we are doing is on patients who are on one or more antidepressants. And in the beginning, we talk to the psychiatrist or the referring physician to make sure that whatever the medication they are taking at that time to stay on the same and no change of medications throughout the treatment so that we don't affect the motor threshold, especially the benzodiazepines. As far as the antidepressants are concerned, there are 3, 4 antidepressants. So we take detailed history as to which one was effective at what time and which one stopped being effective, which one was added later. And based on patient's response, if they feel that 1 or 2 antidepressants have helped them to at least function little better than before, but still depressed, we try to keep them on. And we use TMS as an add-on treatment. I mean, the ECT literature clearly shows that neuromodulation therapy, even though antidepressants were not effective in the first place, but those who are maintained on antidepressants after the treatment seem to have less frequent relapses. So therefore, we try to keep them on what they thought was little helpful for them.
One more question, I think, with regard to if you can explain in terms of it's a 30 sessions, and some of our panelists and as well as who attendees have been thinking about it's too long. 30 session is too long. Is there any way we can overcome that one? Is there any
Well, I think Dr. Vijay mentioned it that the multiple sessions on the same day are being tried, particularly for addiction and even for severe depression. At Stanford, at the inpatient unit, they are using like 5 to 8 treatments per day, so they can deliver all the 13 the 3 days, because that's how long they can keep the patient. So, and they have found it to be quite safe. The only one precaution is that between treatment, there should be at least 45 minutes to hour and a half gap, so that the neurons can restabilize. And we have done it in our centers. I mean, we have those who are not responded to, and they had various commitments. They had to finish their treatment in 15 days. We have given them 2 treatments a day, and we'll ask them in between to go and get a cup of coffee, walk around, and come back. And so they can finish both the treatments on the same day. I think it's the cumulative effect of number of treatments than a single treatment. So it can be packed together. At least we know it's very safe.
I think even Professor George, if I correct, in 2015, when we went to the conference, he did tell that they are using 5 sessions in a day, and it was found to be same effectiveness as 30 sessions. So they were completed in 5 days time. So he said that this is the fastest treatment available at that point in time. I think now, of course, ketamine has come, but he told that rTMS would become the fastest treatment available. Something. So one more question, with the rTMS versus ketamine, has any study been done?
Excellent question. I'm glad that you asked that question, Dr. Krishna, because I know treatment-resistant patients, you send them to ketamine clinic, or you have an option to send them to rTMS clinic, right? And there are many ketamine clinics that are run by anesthesiologists who do not necessarily know what to do after the first 3 treatments, and then they try to find psychiatrists for their patients. So we do get number of such patients, and so the patients say that first 3 days they were great, and after that it is kind of depression has come back. So a group of clinicians in Houston have tried initiating treatment with ketamine to immediately give them freedom from suicidal ideation and acute depression, and then simultaneously start them on TMS for maintenance. Okay, and even one particular clinic is in Clinical TMS Society, they showed their, presented their findings where they took all the patients who had not responded to ketamine, rTMS, and they started doing TMS simultaneously with IV ketamine during the same 20-minute period. And they showed a response rate of 87%. So one needs to immediately trigger the response, the other one needs to sustain it. It's quite good, a good possibility. We are considering, because we are having a ketamine specialist who did Johnson and Johnson's research on nasal esketamine, who will be joining our group, and we offer that to um, probably the entire city of Chicago. I mean, whoever have really treatment resistant of all kinds, to try this option, you know. So yeah, it is being done.
Then I think this will stand almost equivalent to ECT then, ketamine with or more.
Yeah, you're so right, because ketamine somehow almost extinguishes the suicidal ideation. You know, we all know the difficulty of admitting a suicidal patient to the hospital and starting on an antidepressant, and which has not kicked in yet, but we already have to start thinking of discharging, right? And at least with ketamine, we know that we take them into a trance and their suicidal ideation is gone, and it may come back, but then to sustain it, if you have something like TMS, that would be great. And so that's being done.
So one more question, I think a couple of them. I think they want to know, so one of our colleague wanted to know how rTMS works in autism as well as in smoking. What is the mechanism of action?
Oh, the coils particularly are deep TMS coils. They are figure eight coils, but they are beaming their cone, the focus cone, onto the ventromedial part of the brain, thereby having access to ventral tegmental area, which is the seat of all our addictions. So that approach has been helpful. The frontal pole approach has been helpful for nicotine cessation. So like I said in my presentation, possibly it has got a great opportunity to address the same ventral tegmental area involved in all addictions, in eating disorders and alcohol, substance abuses.
I think there's a lot more questions in regard to hypersexuality as well as default mode network. I think we can go into depth of that one. It's a more of a neurobiology. And I think it may take time if you are able to answer that. What is default mode network and things?
Well, said very simply, default mode work is when you think you're not doing anything and your mind is at rest. How the brain waves are happening. Okay, it's happening like ocean full of waves, but actually, as opposed to one's assumption that when brain is calm, the default mode network will be, waves will also be calm. That's not true. It's the opposite of that. It is firing all over the place in a almost like erratic manner until you bring the mind to a focusing on something. Then you see that irregular pattern will stop all over and gets focused onto one area of the brain where either you're reading, listening to music, or thinking or whatever. So that area gets all the focus. Otherwise, default mode network is just the brain as it is. That's easy to measure for research because you are asking the patient to, in the fMRI scanner, put their head in, and the scanning time required is only 8 minutes. It's not like 45 minutes, it's 8 minutes, all we need to acquire what we need for functional connectivity. And during that time, patient can be doing whatever they're doing or thinking whatever they are doing, because if you make it a particular focus of thinking, and it's very hard to get consistency among various research centers. So it's just be as you are, think whatever you can, doesn't matter. That is default for network.
Okay. Is there any a portable version of rTMS as of now for treating depression?
Yes, it's been there even before the rTMS got approved for depression. It's not, but unfortunately, it's not for depression, because for depression, um, the amount of magnetic field generated is 1.5 Tesla, just like in MRI scanner. It's like, can I take MRI scanner to my home? And because the coils required to generate that intensity, the capacitors is very heavy, very big. The migraine one is portable, but that is applied to the back of the head. It's got two handles. That is much less intensity and portable, but it's not good enough for depression. There is also a non-portable device for pelvic magnetic stimulation for women, particularly who have got urinary incontinence. So again, they have to go to the office and sit there because the stool is very heavy.
Yeah. So, all right, okay. So I think I'm almost at the end of that at this point in time. Questions. I think most of the questions has already been answered by you in the Q&A. And I think I want Mr. Ganeshan to know that if he can send the recorded version to some of the participants who have already participated. So they want the video of this so that they can understand rTMS more.
Yeah, Mr. Ganeshan can forward it to Sumantro.
Absolutely.
Sumantro can
I will
share.
what I will do is I will share it with all the panelists, and then whosoever is asking for it, you can share it with them. Also, what I will do is I'll put it on the YouTube and then upload it, so it becomes public. Anybody you can go into the YouTube and see the whole program. Both the things will be done.
Yeah, thank you, Mr. Ganeshan.
Thank you, Mr. Ganeshan. I think that's a wonderful idea.
Yeah, I think I'm handing over to Mr. Vijay. Sorry, Dr. Vijay. So.
Yeah. I think we had an excellent session. Professor Murali went through the basics and helped the participants understand the basics, how the rTMS works and things like that. So that was stimulating. That itself was stimulating rather. And Dr. Vijay, with his demonstration as well as practical aspects, he took us a good tour of how it's done and what are the limitations, what are the indications and all that. Dr. Krishna, with your interactive, you led the interactive session very well. Mr. Ganeshan, as usual, you've been supporting us. Thank you very much. And we have an excellent partnership with Tele and we have been running this. And as you promised, please let's also share the recording and pass it on to Mr. Sumantro. Sumantro is an excellent team member with mindfulness, and he has been the key person who coordinated and brought Tele Arogya, Mr. Ganeshan, and Mindful TMS, all three of us together. So the credit must go to Sumantro for taking a lead on this. And I thank Mr. Premkant also, who have been helping us with sharing videos and things.
Thank you, sir. It was a privilege.
Absolutely. And without the participants, these programs cannot be run. So I must thank all the participants. I know there are quite a lot of parallel programs going on. So that is the main reason why we may be having less number of participants. Nevertheless, we had an engaging participants today. and they were very proactive in asking questions that told us that they are very much interested. There's too much to be learned. This is not going to happen in 1.5 hours. So thank you for your patience on a Saturday night. Thank you, Professor Murali, Dr. Krishna, Dr. Vijay, Mr. Ganeshan, Prem Kant, and Sumantro. Thank you very much. And thanks all the participants once again. Have a good day. Shubhra.